Good afternoon, everyone. This afternoon, I come to share with you on the topic, supplementation for health, wellness, and control. And this presentation, I believe, is timely based on all of the presentations that occurred earlier this morning into early afternoon. And it is so because as primary care clinicians, and I call ourselves as pharmacists, pharmacy clinicians, because our patients depend upon us to guide them with their pharmacotherapeutic management and also those over-the-counter management as well. And what we know to be true is that drug interaction is important, and it is something that we must consider when we're caring for our patients. So as pharmacists and providing pharmaceutical care, we not only provide care in regards to prescribed medication, but also for supplements and other over-the-counter medicines that our patients may use from time to time. So the objectives for this presentation are as follows. We want to look at the role of supplements for the management and prevention of non-communicable diseases with special focus on hypertension and type 2 diabetes. We want to identify supplements that can prevent and manage diabetes, hypertension, and to outline common interaction that exists between the two, and also to summarize in the end with case scenarios and activities. Now, I want you to bear with me. I know it's the last presentation, but pay keen attention to the presentation. There will be a lot of giveaways, so if you don't pay attention, you will not be able to participate in the case section. So we have heard the definitions for dietary supplements, but just a synopsis as to what it really is. These are products that are used to either augment and enhance our daily nutritional content. So what it means for us is that most of the times we lead very active lives, and truth be told, we try our very best to eat the correct food in the right proportion, but unfortunately, we're not able to do so. And as such, we depend on supplements to fill those gaps. So in terms of supplements, we have a broad umbrella under which they fall. We have our micronutrients, which we regard our vitamins and minerals. We have our herbs, amino acids, and enzymes as well. Those are missing from the bubbles, sorry. So we're looking at the benefits of supplements in NCDs. They have antioxidative benefits, they support many physiological processes, and they combat, of course, nutrient deficiencies. So antioxidative benefits of micronutrients. Now, we all need oxygen as humans to survive. But when we utilize oxygen, what happens is that we produce what we call reactive oxygen species, ROS, or we regard them also as free radicals. Now, the accumulation of free radicals over time, of course, destroys our basic functional unit, our cells. Now, if our cells are being destroyed, what it means is that our tissues, our organs, our organ systems will also be affected. And, of course, because of this issue, we would recognize, of course, that non-communicable disease will be a must. So studies have shown that most non-communicable diseases are as a result of oxidating effects or results from free radicals, of course. So excessive production of reactive oxygen species or free radicals, as says, it destroys at the cellular level. So what it does at the cellular level is that we have peroxidation of our lipids and our DNA. And when we talk about lipids and DNA, we have to talk about our cell structures. So if we're destroying that, of course, we're going to have onset of non-chronic disease, we regard as NCDs. So examples of those, of course, include atherosclerosis, endothelial dysfunction, and so forth. Now, separate and apart from the natural pathological processes in our body that produces these free radicals, we also are exposed as a result of cigarette smoking, be it first-hand or second-hand cigarette smoking, and also to heavy metals, exposure to sun, and alcohol. Oxidative stress is currently suggested as the mechanism underlying all NCDs. So we recognize that this is important. Our bodies are wonderfully and beautifully made. So for every bad effect that it produces, it also produces those combating mechanisms that offset these unwanted effects. So these are, of course, in the forms of antioxidants. So what I'm saying to you is that our bodies have a way of naturally getting rid of these free radicals that are produced, right? So antioxidants does this in two ways. It neutralizes the reactive oxidant species, and it also decreases the production of the reactive oxidant species. It does this, we can categorize this mechanism in two separate groups. And the first one we're looking at is the antioxidative enzymes that resides or lives naturally within our cells. And these we regard as our enzymes. So we're taking into consideration the superoxide dismutase, catalase, and glutathione peroxidase, which prevents the formation of free radicals. So if we recall earlier, what I said is that during the utilization of oxygen, we produce these free radicals. An example of such is the superoxide and ion. Now, the superoxide dismutase, which is the SOD, natural enzyme living in the body, goes in and converts that free radical into hydrogen peroxide. But hydrogen peroxide is still not good for us. So the additional enzyme catalase and glutathione peroxidase also goes in and further breaks down that hydrogen peroxide to water and oxygen, which does not cause us any harm. And the second component that helps to facilitate these processes are our micronutrients in the form of vitamins, vitamin C and E, minerals, selenium, zinc, and copper, and of course phytochemicals such as our beta-carotene. So further down in the presentation, we'll get to appreciate how both the enzymes that naturally live, live within the cells, the micronutrients that we absorb from ingestion, works together in synergy in order to mop up and get rid of these free radicals that we know are very harmful to us. Micronutrients also support physiological processes. So vitamins and minerals function in the human body as metabolic regulators, influencing numerous physiological processes. All physiological processes within the body are directed or influenced by enzymes. And it may seem that we're straying into enzyme, but we'll soon connect the dots. The basic task of enzymes are to build up and break down various chemical components, and these are usually proteins. So proteins form our cell walls, hormones, and neurotransmitters. So you see, if these enzymes are not working, then it means that our whole physiology would be out of place. So micronutrients are biological catalysts as they serve as one, cofactors and coenzymes. So what it means by a cofactor or coenzyme is that it helps the enzymes to carry out their work. So these micronutrients, I'm saying, if we're not taking adequate supply of it, or if we have suboptimal level in our plasma, then our enzymes that should get rid of these free radicals cannot work. Enzymes on their own, many not all, are inert without the use or addition of micronutrients. So we're looking back at this diagram and we recognize that where we have the SOD, vitamins and minerals are needed for that process to work. So the vitamins and minerals important here, remember we look at our vitamin C, our vitamin E, zinc, magnesium, and copper. And for the vitamins and minerals for the catalase and the GPX, we're looking at, of course, the selenium, which is a phytochemical. So we recognize enzyme plus micronutrients work together to get rid of free radicals, right? So there are factors that lead to nutrient depletion in our bodies. We have changes in food production, genetic engineering, toxic pesticide, and these can impact food quality. So sometimes we think that when we go to the store, we choose the healthier option. It means that we're getting the right type of nutrients. But I'm sharing with you today that depending on how the crop was grown, the cattle was reared, it can impact the quality of the nutrients that are compromised immune system, they would react differently in terms of the absorption and the utilization of nutrients. For patients who are on medication, we're going to look later on an interaction with medications and micronutrients. So malabsorption is also, can also affect nutrient absorption. Vitamin and mineral deficiency often can be very difficult to identify. Dr. Davids, most of the time patients turn up to a doctor is only when they start to have, they are symptomatic. And vitamins, micronutrients depletion is not usually the first diagnosis that is given. It is after we would have exhausted all other diagnoses, exhausted treatment options that are available to us, that then we will start researching extensively to come up with a diagnosis of nutrient depletion. Except in overt cases where we have like beriberi or the scurvy, then we know definitely that would be the case. So suboptimal micronutrient intake can lead to chronic disease. And I thought it fit to point out some of the most common nutrient deficiencies that are faced globally, so it's not just Jamaica alone. We're looking at the vitamin D, omega-3s, magnesium, iron, and zinc. Vitamin D has become very important recently because in our region, we used to believe that we can never be lacking in terms of this micronutrient. However, lifestyle changes. We have advanced to a stage whereby we drive to work in our air-conditioned cars, we sit in our air-conditioned office, and we're not exposed to sunlight. And in one of my research I found interestingly was that the darker your skin is, or the more concentration melanin is within your skin, is the less likely you are to absorb and to manufacture vitamin D from the sun. So a lighter person would need less time in sun to manufacture vitamin D. The darker skinned person, they say, would need 10 times as much sun exposure. How many of us are getting that? And then they tell us to use sunscreens as well to protect us. So it's a lot of controversy there. So I shared with you dietary supplements for diabetes and hypertension, and there were numerous, so I only focused on the very key ones that we have a lot of conversations around. So our omega-3s, you know that we have the ALA, the DP, and the EPA. The ALA comes from plant source. So for the vegans, they would get their omega-3 primarily from plant source. And these, of course, have antioxidant properties. Need not to dwell further in that because we have exhausted that earlier. And antioxidant properties, of course, we know can help to regulate both blood glucose levels and blood pressure levels. And in this setting too, you find that if it helps to regulate the particular pathology, then the side effects naturally would be either an increase in the blood pressure or decrease in the blood glucose sugar, whatever case it may be, all right? And the EPA, of course, DHA, important. The adiponectin is basically a protein that is used to increase the insulin sensitivity of the receptors that would utilize it to break down glucose. And the same applies. Randomized controlled clinical trials found that omega-3 decreases the risk of cardiovascular disease and events such as heart attack and stroke. CoQ10, a lot of persons have been asking you, I'm sure my fellow pharmacists, for CoQ10 because of the many cardiac benefits that it boasts. So it's important too for diabetes and hypertension. However, it is important to note and advise and to look out for those patients who are also concomitantly taking blood thinners because it does interact with it and it will cause fluctuation in terms of blood pressure and blood sugar balance. Zinc protamine, it increases or it maintains what we call insulin homeostasis. It reduces insulin resistance, prolongs the action and half-life of insulin. So you can just imagine if you have excess zinc in the diet, naturally it can lead to hypoglycemia. The same for hypertension. Zinc is very good for hypertension. However, you recognize on the slide that it works in tandem with copper. So if the copper-zinc ratio is out, what it means is that our patients can be having resistant hypertension, and we're here changing all sorts of different pharmacy strategies, and it's not working because it means that there's an imbalance with the copper-zinc ratio. So the ratio that we commonly use is 8 to 1, but in some studies you see Magnesium is one of those minerals that we'll look at too. It is needed for approximately greater than 300 enzymatic reactions, specifically in the processes of phosphorylation and in general the transference of ATP. Right? It promotes uptake of insulin by cells, and intracellular magnesium regulates the action of insulin. So these are just showing you how these micronutrients can help to create balance in our patients. So the National Center of Complementary and Integrative Health, they have ongoing research. So they're looking at chromium. Chromium is a molecule, or a mineral, sorry, that was said to, in the past, to impact greatly insulin regulation, but more study needs to be done, and as such, they are conducting that. The use of yoga on glucose control in people at risk for diabetes, and ginkgo biloba, which is in many of our energy boosters on diabetes medication. And that is the thing I must say, that because of the limited randomized clinical trials that are available with nutrients, we do not have enough evidence to use it at a therapeutic level, and as such I really advocate that we only use supplements as adhesive or as adjuncts to conventional management, not as therapeutic treatment on its own. Interaction. So we're moving into interactions with nutrient, drug, or disease. So interaction is a consequence of physical, chemical, and pathophysiologic relationship between a drug and a nutrient. The interaction can occur between the drug and the nutrient, multiple nutrients, dietary pattern, or specific foods. An interaction is clinically significant if it alters the therapeutic response or compromise the patient's nutritional status. So what all of this is saying to us is that basically, if the interaction is as such that it impacts the endpoint in the patient, meaning if we're managing hypertension and the interaction causes the blood pressure to go too low, that's an adverse effect. If we're managing hypertension, the blood pressure is still higher or spiking higher, that's another adverse effect, so we need to pay careful attention to those. Supplements contain a large variety of micronutrients and phytochemicals. And the thing about it is, these said micronutrients, they utilize the pathway of the cytochrome P450 enzyme systems. And this cytochrome P450 enzyme system, we know majority of our drug products uses this pathway as well. And as such, what this means for us is that interaction is evident when we're mixing our conventional medicine with our supplements, and as such, it must be managed. So the clinical significance of any particular interaction depends on the seriousness of the dose-related toxicity and the extent to which the systemic drug concentration increases. The latter lies on multiple factors. So we're thinking about the bioavailability of the interacting drug, the concentration of the nutrient that is taken, and I stress that because remember, at a certain concentration, the supplement is no longer a supplement but a treatment. So the concentration impacts on how we regard the supplement. The vulnerability of the patient to the interaction. So if the patient, for example, is in renal failure and the drug would have been excreted from the body via kidney or the nutrient, and you give the patient a medication that should be renally excreted along with the multivitamin, then what you find is that you're putting the patient in further problems. These interactions can result in decreased bioavailability of drug causing treatment failure or increased bioavailability causing toxicities. The patient's nutritional status and dietary components with pharmacological activity can affect drug metabolism, thereby altering action and function. Medications play a significant role in depleting nutrients. Drug-induced micronutrient depletion may be responsible for the unexplained symptoms that sometimes our patients suffer. So the patient may start taking, for example, an ACE inhibitor, and after a while the patient is saying, listen, I can't taste my food, because depletion of zinc over time will lead to a condition where the patient can't taste salt, sweet, bitter, nothing at all, and the patient may not want to take. How many of us knew this? So we wonder, what the patient meaning can't taste? What not getting enough zinc from diet and as such is suffering a nutritional adverse effect based on haste. So medications can affect nutrients by decreasing food intake, decreased nutrient absorption because they're competing for the same enzyme systems, slowing down nutrient production, interfering with their metabolism, and increasing their excretion. So some of the most common drug-nutrient disease interaction for hypertension and diabetes are categorized drug category interaction outcome and recommendations, because I like it when we're very practical. So I say we need to monitor for this, we need to look out for that. What are the practical things that we must work with? So for antihypertensives, the ACE, ARBs, calcium channel blockers, beta blockers, diuretics. ACE inhibitors and ARBs deplete zinc and increase potassium levels. Remember I said pay attention to the presentation. How do we offset this or prevent it in our patients who need these medications? We need to ensure that they're on a vitamin that contains at least 30 milligrams of zinc. Calcium channel blockers and thiazide diuretics deplete potassium. So we need to ensure that these patients are on less than 100 milligrams of potassium supplementation per day. Beta blockers deplete the very good CoQ10 and vitamin B3, which is also called niacin. And beta blockers, what we do to compensate for this, we say take a supplement of CoQ10 100 to 200 milligrams per day, vitamin B3 between 16 to 18 milligrams per day. So these are useful things that we can now look out for hypertensive patients on these medications. So I'll pause and recognize persons taking a little note. All right. So for our diuretics, loop and thiazide diuretics deplete magnesium, potassium, and zinc. So to compensate for that, we say magnesium 250 milligrams per day, potassium of less than 100 milligrams per day, zinc less than 30 milligrams per day. And potassium sparing diuretics deplete folic acid, so we're recommending folic acid 400 micrograms per day. And for oral hypoglycemic, so in the past, most studies would have shown that if the patient is on metformin, then we need to supplement with B12. However, what we're seeing in new research is that not only is metformin a culprit for this, but also other oral agents such as the glipizide, sitagliptin, and so forth. So we're recommending 400 micrograms per day of folic acid. Insulin, so most of our diabetic patients are on omega-3 because they want to protect the heart. So both insulin and omega-3 works in synergism. So the hypoglycemic effect of insulin is intensified with omega-3 supplementation. However, at a dose of less than 300 milligrams per day, the patient should not suffer that adverse drug nutrient effect. And we're on to our case activities. All right, so let's pay attention to the cases so that we can answer. So a 68-year-old diabetic woman visited the cardiology clinic with the chief complaint of palpitation at rest and with minimal exertion. She had a history of type 2 diabetes for around 9 years, treated with metformin 1,500 milligrams per day and pioglitazone 45 milligrams per day. Her other medications were as follows: the aspirin, atorvastatin, losartan, calcium with vitamin D. On physical examination, she was to some extent pale with some icterus. That only means that she looked jaundiced or a little pale. Otherwise unremarkable. 12-lead electrocardiography was normal. Showed normal left and right ventricular size and global systolic function with mild to moderate mitral regurgitation and normal pulmonary arterial pressure. Laboratory examination reveals severe macrocytic anemia with very pale red blood cells that are ill-shaped and teardrop cells on peripheral blood smear table. Her thyroid function was normal and she was not taking any proton pump inhibitors or antacids. What is the suspected diagnosis? I'm not hearing what you're saying. What is that? That means it's right? Oh, that is true. I am very sorry. This mic keeps dictating where I go. But from the case, how do you know that it wasn't in a ratio of 8 to 1? So if we're paying attention, we would recognize that the patient was also on losartan. And losartan has the potential to deplete zinc and increase potassium levels. So we want to check the potassium levels and we want to check the zinc levels as well. All right, so remembering now, right? Case number 2, pay attention. A 65-year-old woman referred to the pharmacy clinic with the chief complaint of palpitation at rest and low blood pressure. She had a history of hypertension for around 6 years, treated with an initial management of the tried HCTZ 12.5 milligram per day with nifedipine 40, then they switched it up to increase the dose of the thiazide, then they add a calcium channel blocker to her treatment. With all the pharmacotherapy adjustments, the patient's blood pressure was consistently unstable and compliance became a challenge. With further investigation, the patient informed the pharmacist at one refill of her medicines that she does not like taking prescription medicines and oftentimes substitute them for herbal therapies. The pharmacist advised the patient to stop that practice as this may affect her overall care. The patient's daughter, a nursing student, did some research online and recommended the following supplements. Sounds like our patients, right? Magnesium 500 milligram once per day, fish oil 300 milligrams once per day, and B complex. After approximately 2 months of taking the supplements along with the medications, the patient noted very low blood pressure reading with high heart rates. She complained of lightheadedness along with fatigue. Note that the patient takes nifedipine 40 milligram once per day now and losartan 50 milligram once per day along with her new supplements. What do you suspect is happening to this patient? Okay. Right. 250, correct. All right, somebody else, very good, but I'm looking to see if somebody else wants to try. All right, go ahead. I may give her a bigger present depending. Okay, go ahead. Okay, all right. You didn't hear what the first lady said? All right, you want to, all right, I'll just go through it because she was correct for the most part. So non-compliance to pharmacotherapy and concomitant use of herbal remedies with prescribed pharmacotherapy, because we saw whereby she was non-compliant initially. So that could have explained why she wasn't getting the results from the medications that she was placed on. The daily allowance, as she correctly said, for magnesium, 250 milligrams per day is recommended. You can go to as high as 350, but not exceeding that. Exceeding 350, we start to treat the supplement now as a medication and not as a supplement. And magnesium can greatly lower the blood pressure. It can cause the tachycardia, the palpitations the patient is having, and as such, that was the issue in this patient. So I think she deserves a basket. I think she really deserves a basket, Michael. Yes. So what other micronutrients would you be concerned about and why? Anybody else want to try for a big basket? Okay. Very good. Very good. So she got it right. This young lady in the front here, well, not really to the front, but 3 rows. So we're all getting the answers for the cases, right? Excellent. And the final case, so let's pay attention. The final case, a 55-year-old male, listen to this one carefully now. A 55-year-old male was admitted in April 2011 after being found lying naked in the street, talking to himself and cursing passers-by. He was taken to the hospital by his relatives. Mental status exam showed that he was unstable and he had difficulty concentrating, had slowed reactions, and got a score of 20 on his MMSE exam, indicating moderate to cognitive impairment. Other symptoms included diarrhea and scaly skin. Given an admission diagnosis of psychosis, he was treated accordingly. After 3 days, his cognitive function did not improve. Upon further probing of his relatives, they shared that the patient has heart and blood pressure problems for about 7 years now and was taking several medicines for that problem, and those medications included a beta blocker. What do you suspect is happening to the patient? We have 5 minutes, guys. Come and get it. All right, I guess we won't remember that one. Go ahead. Excellent. Who said that? Yes, I think we should give her a clap. Excellent. All right, so we have another basket? All right, this is a very big question now. What is the name of the condition that is associated with vitamin B3 deficiency? No man, we really need to clap her. Excellent. We got that? Pellagra, P-E-L-L-A-G-R-A, that's a condition for niacin deficiency. So it impairs your cognitive function, and some patients perhaps with the diagnosis of psychosis may just lack vitamin B3. So in concluding, thank you so much for the support. So just a few concluding statements. Supplements such as micronutrients play an important role in metabolic and cellular processes. Their deficiency due to an increased clearance or deficiency in ingestion may contribute to secondary complications in chronic diseases such as hypertension and diabetes. Their administration as supplements are important to achieving health, wellness, and control. Administration, however, should be carefully monitored to reach adequate doses in order to achieve the expected effects while avoiding reaching concentration that may produce adverse effects. I thank you so very much.